it's time to introduce our directors, Stewart Campbell, Gorham, Ron Singer, who came back from Los Angeles full of knowledge and are going to entertain us and educate us with everything that's new in prostate cancer research. So who's first?
Well, ladies and gentlemen, this is a presentation. This is a presentation by 3 lay people who all have prostate cancer at various stages of disease. And it's just coincidental this year that the 3 of us happen to also be directors on the board of the Prostate Cancer Canada Network, Calgary. The theme of this particular conference was making a positive impact on the quality of life. And I've attended this conference 3 years consecutively, and it's fair to say that each year there's some new outstanding research that comes forward. So stick with us. This is going to be maybe a little long, but there's going to be a message for each and every one of you in this particular presentation from the 3 of us. And we're only touching highlights. We do have 4 videos, 4 sets of 4 videos that you will be able to obtain off the library and be able to sign those out and to take them home, return them the next meeting, and you'll have a full month to go through what we took in over the course of 2 days. And now you're going to get about a 1-hour presentation. The purpose, well, fundamentally, the PCRI believes that a patient who understands his disease and treatment choices will be empowered to communicate more effectively with his physicians and to obtain a better outcome. PCRI uses all of the available communication tools, programs, even they have a helpline. They have a quarterly and weekly newsletter and a website. The speakers that they choose come from the leading, they're medical doctors who come from the leading prostate cancer practices in the United States. And you'll see this evident by some of the presentations that we have chosen to highlight. Now, it's been their experience, and it's certainly our experience here, that you do need to put yourself into a particular category of prostate cancer victim, if you will, or a man with prostate cancer, so that you know how to be communicating what your particular situation is. Treatment choices are different. They vary depending on what your circumstances are. So PCCRI have developed a shades of blue approach to try and categorize the various stages of the disease. And this year they have added something at the top which is called abnormal PSA on the very top left. They created this thing last year, and we're talking in terms of a color of sky, teal, azure, indigo, and royal. And basically, as you step through these particular colors, you'll find that Gleason scores increase, the number of cores that are affected, whether or not a digital rectal examination has been done, and whether the relative staging that comes about as a result of that digital rectal examination, the PSA range, whether MRI, CT scans are recommended, and whether bone scans are recommended and whether they are clear or not. So that is a useful way to rank the stage of your disease. And we will follow that path as we go through the presentations that come forward next. And first of all, I'm going to pass the mic over to Ron.
Hi, I'm going to be probably giving you the least formal and least technical presentation. Stewart and Ron Gorham probably have much more technical issues. I'm going to first, before I get on to my history that Stewart has written up here, I'm going to give you some general perspectives I had on PCRI, because some of you may want to attend. It's a great thing to go to. It was 3 days of non-stop networking and confirmation of thoughts, because it's essentially like coming to a PCCN Calgary meeting for 3 days long and relating to people you've got a lot in common with and a lot you want to share with. So there was the great networking experience. Aside from the actual presentations, there was the informal opportunities to meet and greet people who you had a lot in common with. There was exposure to the newest and best in technology and research, to the degree of a bit of information overload. It was also a great opportunity to compare our system to the U.S. system. They've got, we all know and found down there, they've got better tools and toys. We've got more egalitarian access. However, their treatment modalities are determined by the profit motive. One of the presentations that I think Stewart is going to address earlier, Dr. Blasco, who's a longtime expert in brachytherapy. Brachytherapy is declining in the U.S., not because of its effectiveness, not because of its appropriateness, because it isn't a highly profitable modality. Another little interesting thing in terms of comparing the U.S. and Canadian models, at one of the active surveillance subgroups, I mentioned what Stewart has written here, my biopsy from hell, and talked about how I had some premonition of it because the informed consent material that we all get before we go to a biopsy, and what the stuff here talks about is a 5 out of 200 potential for serious complications. When I talk about informed consent, all these people in active surveillance estates had never heard of informed consent. They were just sent like sheep for biopsies, which I really found strange because we all have the image of the U.S. as being so highly litigious, and yet they don't even go through the informed consent. Just summing up on my overview of the PCRI, the best sessions that I found were most useful were towards the closing of the conference. Rather than the individual addresses, where there would be a panel at the closing, they would be discussing a number of structured questions. Each individual respond to it. They also presented a couple of case studies. And I think there were 3 case studies they presented. And probably most of us would fall into one of those 3 cases. And that was very instructive because it gives you models of where you might be on the continuum that Stewart talked about. Stewart has given you a little bit of my history. My father was diagnosed with prostate cancer at the age of 78. He proceeded to carry on till the age of 88, and having had external beam therapy, and never really had any other issues with prostate cancer. But I was sensitized that prostate cancer was something that I should be looking out for. So probably in my my late 50s, I started having PSAs at a time when PSAs weren't part of healthcare in Alberta, but my doctor, knowing my history, would do special requisitions, and I never paid a cent, and I've got a great time series that has paid off. In any case, in 2008, my PSA started climbing, and December 2008, it peaked out at 7.95. I was referred to a urologist in February of 09. Had my first biopsy, 1 out of 10 cores, a Gleason of 3+3, and T1C was the DRE categorization. That resulted in my urologist saying, okay, you've got cancer, when? To him, it was a simple solution of a radical prostatectomy. Well, I fortunately was invited, as a lot of you have been, to the Rapid Access 2 clinics at the Prostate Cancer Center, heard the speeches, looked at the literature and said, gee, I think I look like I've got the metrics for active surveillance, and got a second opinion from another urologist who agreed with me and gave me a standing order for PSAs every 3 months. And I've carried on with the exception of the second biopsy, with Stewart has written up here as my biopsy from hell. I had, in terms of the results, it was the same 3+3 Gleason, 1 out of 10 cores, and T1C. However, I was one of those statistics that I referred to in informed consent. I was one of the 5 out of 200, ended up with a massive blood and urinary infection, hospitalized for 3 days, and took me 6 to 8 months to get back to myself. You know, that's going to relate to something I'm going to talk to you about in a moment that I learned at PSA. Here, in terms of diagnostics, we have the PSA and we have the biopsy, and that's about it for the tool bag that I've heard of in Canada, and particularly in Alberta. There were other tools that came out at the PCRI. I just, on my history, I had a third biopsy in May of 11, and you know what? I didn't get much in the way of results out of it, because though I'd had 1 core out of 10 in the first 2 biopsies, the third biopsy showed no cores. It showed 1 core with some disorganized cells, but not enough for the pathologist to even categorize it as cancer. So, you know, I suppose I'm a bit of a poster boy for active surveillance, that the mere presence of some cancerous cells does not mean one has to proceed to action. Just got my latest PSA results today from a blood sample I did yesterday, and it continues to drop. So that's where I'm at. And I'm going to now try to discuss what I got out of the PCRI in terms of active surveillance. There wasn't that much in terms of presentations on active surveillance at PCRI this year, because whereas PCRI used to be this radical, off-the-wall, extreme modality, it's now part of the conventional continuum, the continuum that Stewart showed you in that spreadsheet. Dr. Blasco, who talked about low and intermediate risk, was talking about active surveillance. So it's part of the conventional. So there were threads of active surveillance through, but it's not a big issue. It's part of conventional thinking about treatment and diagnosis of prostate cancer. However, I talked about, you know, my biopsy from hell. I talked about that here we have nothing between PSA and biopsy. In a couple of presentations there are other diagnostic modalities in the States. One is color Doppler ultrasound. The other is multi-parametric MRI. And we don't use them in diagnosis here. I confirmed with the office of one of our leading urologists here this morning that in fact we do have both of these technologies here. We do have the diagnosticians who can read them, but we're not using them in diagnosis and progression. And that's something that maybe we'll have to talk about at the board level. Maybe we'll have to get speakers here to from the diagnostic community in radiology and see whether we can have this, because I run the active surveillance subgroup every month, and there were, I believe, 3 people tonight who talked about some very, very adverse experiences they'd had with biopsy. So I'm not the only one with the biopsy from hell. And so, you know, that was, from my viewpoint of being the active surveillance advocate, that was probably one of the greatest things I learned, is that we have some other tools. And, you know, whether there are going to be institutional financial barriers or not, I don't know, but we have other tools of diagnosis for people who are in the early to intermediate stages. There was also a discussion in the one presentation that did deal with active surveillance about focal treatment, not treating the whole prostate, but treating parts of it. Also, somebody who we've heard speak to us a number of times, Dr. Moyad, talked about the use of drugs that are for advanced forms of prostate cancer being potentially tested in future for earlier stages. And the model he used is, you know, maybe in future we'll be treating early stage prostate cancer as we treat lipid control, that as statins are used for people who are showing signs of issues with circulatory cardiovascular issues, that maybe what we see now as the high potency, extremely expensive drugs will eventually be used for early stage prostate cancer to keep it under control. So those are some of the meaty issues that I got in terms of active surveillance. I'm going to give a couple of remarks on what I think were some of the epiphanies, the words of wisdom that I heard at PCRI. And some of you have heard me harp on my own. These are confirming of my thoughts. Dr. Mark Schultz, who's the executive director of PCRI, said this in one of the presentations. Prostate cancer is the only cancer in which surgeons act as the primary care providers. They are men of action. They are trained to do surgery. That's something I learned, you know, when my father was involved and my involvement. That there, and what Dr. Schultz proceeded on was that there's a great deal of overtreatment because these men of action like to get in there and do their surgery. You know, his suggestion was that there's not a need to even rush to biopsy. That, as I was talking about earlier, that, you know, if we had it here, that color Doppler ultrasound might be very helpful at these intermediate stages of diagnosis. Dr. Blasco, who it was the man referred to earlier, who is the one of the pioneers in brachytherapy. He had he's in semi-retirement now, so he's got a very reflective way of looking at it. He, you know, said that one should not look at prostate cancer as a single frame, but watch the whole movie. That what we do in this organization and other organizations, that we should be exposing ourselves to the whole movie, the whole nature of the disease, the progression of the disease, the tools that the disease has. He presented a slide, I was going through the DVD this morning, where he did an analysis for low to intermediate patients of active surveillance versus surgical modalities. And on just about every metric, including quality of life, active surveillance was coming about equal to surgery, so that there are situations where surgery is the only route, but his analysis of studies was that active surveillance can be just as good for a lot of people. So that gets back to what I was saying earlier, that active surveillance is mainstream part of the toolkit nowadays. And
how do you define active surveillance?
There's a slide.
Okay, so Dr. Blasco defined the active surveillance versus the old term watchful waiting involves periodic testing. I get a PSA done every 3 months. I've had 3 biopsies already. Tomorrow I'll be meeting with my urologist and we'll discuss whether another one is appropriate. It'll be a better part of 2 years since I've had one done. So active surveillance is actively monitoring. You know, we all know that prostate cancer in most individuals is a slow-moving cancer. So you know, keeping on top of it will lead you know, will not let it get out of whack. Next one.
Is there no further scans required to see if the cancer has spread? Is that not part of the active surveillance?
Yes, sir.
Well, your biopsy will if you're having biopsies done at intervals, and you know, various of the speakers talked about what the intervals should be. You know, Dr. Claude says, you know, whether you go, you know, one year for the yearly apart for the first couple of years, and then you know, 2 to 5 year periods. I mean, getting in there and doing a biopsy will tell whether it's spread, and the PSA being the indirect indicator will give you a clue of whether, you know, something is changing. Just hit that. Okay. Here's the progression of or the bag of things that are used in active surveillance. You know, and I suppose active surveillance is the aggressive form versus the observation, you know, is the lax form. The last thing, because apparently we got to have some levity around this place at all times. Introduced a bit of levity. I went by car down to California. I was away for 18 days, put on 5,000 miles, and we've all heard Dr. Moyed talk about, in terms of our general health and our prostate health, keeping a heart healthy regimen is probably good for our health. Well, you know what? I went away for 18 days and 5,000 miles, and I brought down my blood pressure and I brought down my weight. Both have returned back to normal and beyond. And a good part of it was by being very cognizant of the type of things that Dr. Moyed told us about. And I did a lot of my dining at an American institution that in California is much more attuned to healthy needs. I often went to the place that's described here, which describes the various items that you can get with as little as 100 calories or less. So every morning, to lose weight, every morning I was stopping at McDonald's and having my fruit granola yogurt, and every night having a salad there. And I lost weight and lowered my blood pressure. So I don't know how much Dr. Moyed will support me on that, but a selective diet at McDonald's can work. And that's what I have to say. As I say, it's you know, I've tried to give you a somewhat personal view of it, but it's a great networking opportunity. And at the end of the presentation, I think Stewart is going to talk to you about how PCCN Calgary is going to offer to provide registration to members who want to attend, and it's a great function to attend. Thank you.
The next area that we're going to look at is some of the new diagnostic area that is forthcoming, and I just want to, before we get into that, this conference, you know, or this organization here in Calgary, you know, your board of directors, your people here are very forward-thinking, and the information you're getting here tonight is probably, you are probably the only people in Canada receiving this information. this conference very sparsely attended by Canadians, and I doubt that there's another support group that are bringing back this information to their members. And keep in mind, it's a really good comparison to, as was mentioned, of the U.S. system and our system, and I'll be able to drive that home here at the end. I'm concerned with rising PSA, and here's the reason why. I was diagnosed actually in late 1995, PSA of 11, a Gleason score of 9. All indications are this disease was confined to gland. Early in 1996, I had a radical prostatectomy, and I went to an undetectable PSA, and that lasted for 8 years. I had a continuing undetectable PSA. Then in January 2004, my PSA showed up at 0.1. I was then moved over to the Tom Baker, and they, after consultations and testing, I had 33 radiation treatments of the prostate bed. Whether that did any good or not, nobody knew. At that time, I had what was called a ProstaSynth test, which was the most sophisticated testing to identify where this cancer was. They could not really identify it. It's a test that is no longer used currently, but at that time, it was the best technology available. Now, my PSA from 2004 slowly rose over the next 8 years. So I went another 8 years after the radiation, and my PSA in December of 2011 was came in at 9.03. From that point, at that point, I received a Lupron injection, hormone injection, and immediately, the following April, I went right back to an undetectable PSA. Subsequent PSAs in July went to 0.2, October 0.3, December of this year 0.6, and I have just taken another PSA yesterday. I don't know the results. Move on. One of the speakers at this conference who dealt with this was Mr. Snuffy Myers, American Institute for Diseases of Prostate, and he has a metastatic pattern, and this is his analogies of really what's going on. First thing that happens, lymph nodes in the pelvis, possible movement to lymph nodes in the lower abdomen, then a movement to bone. He uses a PET CT, I think it's called Faragheim scan, to identify this. Then this cancer can move to the liver, the adrenal glands, and the lung, possibly. Of course, when this gets into your liver and your bones, you get really serious trouble. Advances in imaging, just as I mentioned, bone scan and this Faragheim PET scan, MRI-based Combidex, and this is Snuffy Myers' procedure. Now, what's happened, and we had an individual in our group here, Mr. Ken Drager, who went all the way to Holland to have this Combidex scan done. Currently, this is no longer available, and there's reasons for that. There's more sophisticated things coming. And it only sees, it's a limited thing, it only sees lymph node disease. And we'll see any cancer in the nodes. And moving on from that, we now have, there's now just breaking with positive results, is what is called a C11 PET CT scan, choline or acetate. Again, pacemaker's not a problem. This sees cancer everywhere, and it depends on the cancer being metabolically active. Choline is prostate specific. This is his analogy. It's unclear to him if PET imaging can ever match MRI for resolution, but I believe it can. Now, one of the best speakers I've ever heard of was this gentleman, and of course it's no wonder. He comes from the Mayo Clinic in Rochester, but they are leading this technology. He's a professor of urology. Let's see here. We need to bring that up. And we're going to watch some of his presentation.
So we've worked very, very hard to get this thing approved in the United States. The other thing that you have to know is we didn't invent this thing in a barn in Minnesota, all right? This thing is actually a fairly common technique in Western Europe. Now, one thing that you have to know, I mean, I believe that C11 choline PET scan is superior as a single modality for early detection of relapsing forms of cancer. The threshold of detection, once again, is somewhere around 2.0 for a PSA. In contrast, MRI, CT, and bone scan, median PSA for detection of a lesion is 29. So there's quite a lead time provided through this technology. Once again, this technology identifies metabolically active cancer. It does not image static lesions, which may or may not be alive, as does CT or bone scan. And it can definitely see tumors that CT, MRI, and bone scan cannot see. So the panels on the bottom are the choline PET scans, and the panels on the top are CT and MRI, which are blind to the recurrent cancer. In addition, I do have the opinion that I think overall this will be a very economical form of imaging because it's one imaging modality that actually works. The amount of radiation that you receive is roughly on the same level as what you get with abdominal pelvic CT. The other thing that I noted, and I'm glad I put this slide in here, a PET is not a PET is not a PET. So this, what I'm talking about today is C11 choline PET scanning. It is not the same as FDG PET scanning or C11 acetate scanning. We've already done the evaluations, which seems to suggest C11 choline PET scanner is by far the most sensitive device to look for relapsing prostate cancer, superior to FDG PET, superior to C11 choline PET. So in summary, the C11 choline PET scanner is like Doppler radar, and it will show you where trouble is brewing within the body. And now I'm going to move on to the part of the talk which hopefully some of you will get some information out of. This part of the talk is going to talk about where we use the C11 choline PET scanner for evaluation of patients, and this part of the talk will pertain to patients who fail initial therapy. That is, patients who fail surgery, radiation, cryotherapy, or proton beam therapy for management of localized prostate cancer. I'm just going to walk through cases and then we'll talk a little bit. So this is a patient that came into our clinic. His PSA was 0.94. He did not know where the PSA was coming from. He had had a radical prostatectomy, external beam radiotherapy, androgen deprivation therapy, and a very low PSA. He had been imaged a number of times and we could not find sites of relapse. We ran this patient through the choline PET scanner and a little spot lit up at the bottom of his pelvis. And this, in fact, was biopsied and confirmed presence of what we call vesico-urethral anastomotic recurrence of prostate cancer. So this patient finally had his prostate cancer located, and it was treated with cryotherapy since he could not tolerate any further radiation therapy. The treatment was very quick and effective. This is a patient that had external beam radiotherapy of his prostate. He had his prostate irradiated and he was put on hormone therapy. Unfortunately, his PSA started to drift upward to 11.3. We ran this gentleman through the choline PET scanner, and what we found was he had both his seminal vesicles filled up with cancer, and they were metabolically active. So, I'm sorry, this patient actually was treated with surgery, seminal vesicles left behind. So we scheduled this patient to be treated with external beam radiotherapy and hormone therapy to wipe out these lesions. This is a very interesting gentleman. He had brachytherapy of his prostate, and he then had his pelvis irradiated. So you would expect that this patient perhaps would have cancer coming back exactly within his pelvis. His PSA was 10.2. They were wondering where the PSA was coming from. We ran him through the scanner, and the only spot that lit up was in the middle of his chest, in a lymph node next to his lung. And in fact, that turned out to be where the cancer is located. I don't know what happened to this patient. He was referred back to his physicians. But once again, this is a situation where we identified specifically where the cancer is located. This is a gentleman that had a prostatectomy, and 6 months later had his first PSA, and the PSA was 2.7. So he became very panicked. He had a bunch of scans done out east. No site of cancer was identified. We ran him through our C11 choline PET scanner, and we found evidence of cancer growing back in his iliac bone 6 months after his surgery. This was effectively treated with stereotactic radiation and hormone therapy. PSA is now 0. This is a fascinating case. This is a gentleman that actually came to me after he had previously had surgery, and he had a metastasis to his sternum. The sternum was irradiated, PSA went back to 0, but then over the years, PSA started going up again. So the patient became panicked, came to us, and we thought for sure that the cancer would be growing back in the sternum. We ran them through the PET scanner, and lo and behold, the spot where the cancer was recurring was actually in the thoracic spine vertebral body. This patient was treated with irradiation, put on hormone therapy. PSA is now 0. He's doing fine.
There's probably another 10 examples of success and also some examples of failure. So I would invite you to pick up the DVD and see the whole show there.
Okay, from some interesting numbers here. My estimate, 20,000 men each year are going to present to their doctors or oncologists that they have rising PSA after primary treatment. And we can bring that down a little bit further. I'm going to estimate that about 3,000 Albertans will present every year that they have rising PSA. Now that number comes from the 200,000 men that are present in the US with rising PSA. Key questions. Every man should ask his physician about a rising PSA. And I'm stealing something here, but I kind of think that the research should be done a little bit along the line of what are we dealing with? This new imaging is going to allow them to answer that question. How do we find out, and what or which salvage treatments can be performed, and how aggressive it should be treated. Now, everyone is different. Prostate cancer, as you'll find out, is it's an individual disease. You got to make sure that the treatment protocol is right for you. I did talk with some men who had this test, and although they have rising PSA, they could not be, the cancer could not be identified. But they are having extremely good results with this. He did mention in another, anyway, in his presentation, he mentioned that they were seeking FDA approval for this. They did get FDA approval for this in actually late September. And there are, we're not going to show this, they do have, it is on YouTube, you can see where, and he doesn't just to summarize exactly of what we had there, but they did. Now, this is his, you know, kind of conclusion. This is a game changer. He really believes, you know, that this PET imaging with this C11 will identify sites for recurrence, for tissue sampling and examination. And it also allows, of course, to pinpoint recurrent cancer more accurately. And again, extend that to the proper treatments. Okay, I think we talked about that. I'm going to drive this home one more thought. So, two things. There's the two tests, C11 choline and C11 acetate. C11 choline is done at the Mayo Clinic. There is a diagnostic clinic in Phoenix, Arizona that is doing the C11 acetate. We have a member from this group that has gone and had that test done. It is extremely accurate. He is currently traveling. He couldn't be here tonight, but he has 3 spots that were identified by this test. That and he's the same as myself. He's currently on intermittent ADT treatment, and he's having a fight with the side effects of that, and he's trying to convince his oncologist that they should go in and do some form of salvage treatment. Now, next thing, this test is needed to be done by what's called a very big machine called a cyclotron. And as late as yesterday, we found out through a report that there are approximately 11 of these cyclotrons in Canada. And lo and behold, one of them is in the Cross Cancer Institute in Edmonton. Second thing we found out, and as late as over the weekend, the University of Alberta and the Cross Institute in Edmonton have just presented a paper to the Canadian Oncology Association, where in 2011 and 2012 they did a trial of 12 men using C11 choline as a diagnostic. It is so that's brand new to us, but it looks like this imaging is very close right here in our own province. We're making assumptions, and we're going to I'm going to explore this a little further as to how close we are at getting this imaging available to us right here in our province. But we have confirmed they have the equipment, they know how to run it, obviously, and so I think that we're really close. Okay.
Well, I've got a story of a person that presents with aggressive, advanced prostate cancer. So I really chose 2 talks that deal with high-risk prostate cancer. My own journey is I presented 6 years ago with lower back pain, and my family doctor did a DRE, and my prostate was as hard as a rock. PSA 61. So I was very rapidly referred to this rapid access clinic, and it worked very well for me. I had a biopsy done, and there's no question that's intrusive. I don't know if I would call it from hell, but I did almost pass out on the 7th core. And I had the technologist there yelling and screaming at me to stay awake, keep talking, talk to me, what do you do for a job, and this and that, and what have you, just so that I could get over the hill and remain conscious. I didn't feel the remaining 3 cores to get up to number 10. So it's an intrusive biopsy. 5 of 10 cores were cancerous. I then learned from the CT scan and the bone scan that my cancer had gone and escaped the gland, and I had 4 or 5 lymph nodes that were swollen, including one that was outside the reach of external beam radiation. So basically, radiation and surgery would both only have been palliative, and they couldn't have proceeded with curative intent. So I'm a chemist by first training, and so chemistry can't fail me. I started medical oncology right off the start, and I joined this particular group, and I learned about the warriors, and the second night I was in talking with warriors. It just so happens today I'm chair of the warrior group. Anyway, I went on Lupron, and it certainly demonstrated that my cancer was responsive to anti-androgens. The PSA went down from 61 down to a nadir of 0.8, and it held there for about a year, but then began to increase. And Cassidex looked at me, and I looked at Cassidex, and we agreed that not much was going to happen there. I tried it, and it stalled the disease, but it didn't really reduce the PSA. We tried Avodart, and not much success, and I was doubling in less than 3 months. So I had metastatic disease June 2011 with a PSA of 32. It's not a good scene when the doctor says, well, Stewart, all we've got left for you is chemotherapy. And my view was that chemotherapy was a slippery slope. So I said, let's get me onto a research trial. And I was fortunate, really fortunate, to get enrolled in the Medivation 3100 PREVAIL Phase 3 pre-chemotherapy clinical trial in June of 2011. My PSA dropped 93% to 2.2 in a matter of about 2 months. And this trial's blinded, so I don't know that I'm on the drug. I'll let you conclude whether I got the drug or the placebo.
You got a hunch.
I got a hunch. My PS today is 3.5, and I've now got enough of data points to suggest that the doubling time is now 14 months. So not only did the PSA drop, but also I've quadrupled the doubling time. So that's all pretty exciting stuff, but let me continue. High-risk cancer. Dr. Lam, prostate oncology specialist from Los Angeles. The demographics of this particular group, about 15% of the US men present with a high-risk disease. And the mortality at 10 years averages somewhere between 5 and 15%. And there's a consensus amongst the experts that you need to be treating aggressively. Radiation, ADT, generally better than prostatectomy. You'll note that my choice was not necessarily an aggressive approach. The definition of high risk, localized cancer with a high likelihood of microscopic spread. So when you do this various scanning with the conventional devices that we have, you can't see where the prostate cancer is. And it's quite possibly with CT11 choline that you can't see the microscopic spread of the cancer as well. So what you find is that your CT scans and the bone scans are normal in a high-risk category. PSA greater than 20, Gleason 8 to 10, and maybe a couple of other risk factors. And a more serious grade of high risk would be where you've got a 4-5 or a 5-5. And you've had confirmation that there's been escape through the seminal vesicles and also into the lymph nodes. So this calls for multimodal, multi-pronged attack. And the question would be whether you start out with surgery or whether you start out with radiation, external beam radiation. It's a good question. And is surgery appropriate for high risk? Now remember the very early shade of blue that I was talking about. So I'm talking now specifically about this high risk category. There may be, the conclusions may be different for lower risks. So if the cure rates of surgery alone are poor in the high risk, if men need radiation after surgery anyway, and if men need ADT after surgery anyway, why not skip surgery and proceed with radiation? Good point. This is a really, really intriguing graph. On the left axis, as you go up, could be viewed as treatment success. It's all tied to the PSA analysis. And the horizontal numbers along the bottom are the years from treatment. And there's an overwhelming number of studies that suggest that brachytherapy plus something else works better than surgery plus something else for this particular stage of the disease. And we have very, very good brachytherapy capabilities here. And much better, performing much better than just the external beam radiation by itself. So how do you improve these radiation results? You improve them by expanding the region that is being irradiated. I spoke about that last year coming from the conference, and so this is not just radiating the prostate, but radiating the entire pelvis area. It also involves increasing the dosage within the prostate by implanting seeds, or possibly using focal image guided types of technology. And it does include androgen deprivation therapy, and it might include various forms of chemotherapy. So for this high-risk group of people, it's a sequence of various therapies that will be required to set this disease back, and possibly even back on its knees. This is a very, very interesting study, very recent, with 29 men only in high-risk disease. And these are men who received abiraterone and Lupron prior to going into surgery. The stunning aspect of this is that these men going into surgery had less than the 0.2 PSA. And at the time of surgery, 24% of these men had cancer that was less than 5 millimeter. I think typically you might be able to see the cancer with conventional scanning in the range of 1 to 2 centimeters. And 3 men had no cancer seen at all. So it was said that this is a great response that's never been reported before. It's provocative, but clearly more studies needed. So this is keeping surgery on the table but using some of the new drugs as well to prep you for the surgical treatment. And some of these new drugs are highlighted in this presentation by Dr. Dreiser from the Cleveland Clinic. No small clinic. When people were looking at the various clinical states of prostate cancer back in the year 2000, so this is before docetaxel, what you basically had was a disease identified, you had rising PSA, you had available castration, and you had available some drugs that were equivalent to chemical castration. And that was it. You would find yourself in a situation of rising PSA, moving forward into metastatic castration-resistant prostate cancer, and eventually either death from some other cause or death from the disease itself. So that's the year 2000. Awful lot has happened. 2004, docetaxel came in and was the first drug that demonstrated positive extension of life by the use of the docetaxel. There were side effects there, and so that's why I'm not choosing at this point in time to be considering the docetaxel. But in the last 3 years, 5 new agents have been approved by the USDA or have come through trials, and submissions have been made to the USDA for US FDA for approval. This is a stunning list of new drugs that are available, and they're coming into Canada. We have Zytiga or abiraterone available to men today, and we have men within our Warriors group that are on abiraterone at various stages of their disease. We have Xtandi, or this Medivation 3100, where I've said that I am now in the PREVAIL trial, and that trial is ongoing. But the company is mobilizing so that it can, this year, so that it can be effectively rolling out this drug as soon as it is approved by Health Canada. And we have 3 other drugs here. The important thing is that each of these drugs are operating through a different mode of action. They're not all the same. So it's there's a possibility then of a multi-pronged approach to tackling this disease once it's in a rising PSA situation, and that's particularly relevant then to high risk and to the aggressive high risk prostate cancer people like myself. There's also 2 bone builders that are approved. And available in Canada, but not necessarily funded uniformly across the country. So now the clinical states model that I described for 2000 is vastly different today because of how these various drugs will interact at the various stages of the disease. While it's complicated, it's also giving one an incredible number of new tools to be able to work with and to choose, provided they're funded either through your public insurance or through your private insurance, and whether they're approved, first of all, I guess, by Health Canada, and the willingness and the receptiveness of the oncology community to be somewhat experimental in their use of these particular drugs, and for you to be capable of accepting some risk and uncertainty relative to the use of these drugs as well. But like I say, there are 5 new drugs, 5 different modes of action, and there is some logical pathways that can be followed for each of these. Now, a drug that is much earlier in the research pipeline is this XL184, and the stunning results of it are seen by the conventional bone scans of an individual on the left who had bone metastasis throughout his body. And there was, after 12 weeks, just an incredible change in the resolution of the disease. This is still too early to know if this kind of radiographic treatment change actually results in any improvement in survival. It did result in substantial reductions in pain. There was no question about that. And it did result in substantial reductions in 2 markers that you see in the little graph on the lower right. This drug may well be available to us soon via a research trial, and I'm only speculating on that. So keep your eyes posted, because if you're eligible, this is certainly something to be giving serious thought to. Now, that's my concluding remarks, other than there is going to be the conference in 2013 in Los Angeles, September 6th to 8th. Ron has already made mention to just how significant that conference was to him. About 800 men, just like you and I, were attending, and these are high-quality, high-powered physicians, clinical physicians that are talking about their own experiences coming from research and their own clinics and the likes. And our board has decided that this conference is so significant that we're prepared to pay for the registration fee of 10 members to attend this conference. It would be for you to fly down to Los Angeles and to get your hotel for 2 nights at, well, in this case, it's the Marriott Los Angeles Hotel. You can be leaving on a Friday, you're back on a Sunday evening, and it's well worth the time and your commitment to be there. So, Prostate Cancer Network in Calgary is going to, it offers that to you, and it's for you to come forward to one of our directors here, or to come forward to Bob and show your interest in going. And that's our presentation of this particular conference, and some presentation, I think, of some rather stunning results.